Welcome to the Bone and Joint Playbook with Dr. John Urse, where we explore an extensive range of orthopedic topics and insights. Our goal is to help you understand the available orthopedic options and treatments available, and hopefully give you some answers to questions you might have. We want to thank our following sponsors.
Ted's Authentic Greek Salad Dressing and Marinade. It's healthy, gluten-free, and delicious. You can find Ted's in Dayton, Ohio at Dorothy Lane Markets, Health Foods Unlimited, and Dots Markets. That's Ted's Authentic Greek Dressing and Marinade. Thanks, Ted.
We would also like to thank
Stifel's GWR Group combines more than 65 years of experience helping high net worth clients consolidate, coordinate, and simplify their wealth planning strategies. The group has access to a full suite of resources to serve all of your financial needs. Email gwrgroup@stifel.com or call 937-353-2863 to speak to Guy, Brad, or Jeff Richardson. Stifel, Nicholas & Company, Incorporated.
Welcome, folks. We're back here with the Bone and Joint Playbook with Dr. John Urse, and we have a special guest with us. Dr. John, why don't you tell us who this young man is?
Well, this is Dr. Andy Malarkey. He's full disclosure, he's my partner. And Andy's got quite a training pedigree. He did his undergraduate at Transylvania University. Him and Count Dracula both went there. He went to medical school in Athens, Ohio. And then his orthopedics was done at Grandview Medical Center in Dayton, Ohio, all part of the Kettering Health Network. And he did 2 fellowships, one in hand and elbow, and a second fellowship in shoulder and reconstructive surgery in Fort Lauderdale. So this is a highly trained person who is well-versed in order to tell us about our topic today, which will be the reverse shoulder replacement. Welcome, Andy.
Well, thank you so much for having me. I've listened to most of the podcasts, the Bone and Joint Playbook, and Dr. Urse actually helped train me, and I'm forever grateful for that. And it was an honor to come back and work with him as his partner. And now that I'm on this podcast, I think I've reached the pinnacle of my career.
This is it. Doesn't get any better.
I might be done after this. So
Yeah.
Thank you so much for having me. It's an honor to be here.
You're welcome, but you got to climb. Man, we all have a certain time of year. This is a holiday broadcast. We're wearing a funny little hat for the holiday season. So we don't normally look like this, but let's have a little spirit.
Let me start with the first question, because when we had this topic come up, I wanted to go right away. I don't quite get, what is a reverse shoulder? What does reverse mean? What's a standard versus what's a reverse?
Yeah, that's a great question, Terry. And I see a lot of patients in the office who have similar questions with that. And the best way I can break it down is that the shoulder joint is a ball and socket joint. We have a ball and we have a socket.
Right.
And that allows us to have the greatest range of motion of any other joints in the body comes from your glenohumeral joint. We get some motion from the back portion of the shoulder complex, but most of it comes from the glenohumeral joint. Now, when we reverse that, we're changing the anatomy. The ball becomes the socket and the socket becomes the ball. And we have some models up here, and we can go through those in a little bit. But essentially, you're just changing the normal anatomy to the shoulder. And it looks really funny when you start looking at x-rays, and patients are a little surprised when you tell them you're going to change their anatomy. But it has a lot of utility, and we've used it here in the United States for the past 20 or so years, and it's pretty much revolutionized shoulder surgery.
But why? What makes it so much better? What is, I'm still baffled by you're going to change the ball and the socket around, but why is it better?
Well, it's better in certain aspects. It's not always the answer to everything. Originally, when this procedure was designed, it was for patients that have large rotator cuff tears that could not be fixed. And originally, we did not have good options for those patients. I know
we did a podcast on that, right?
Yes.
Unfixable rotator cuff. We said the worst thing you could do is take a huge tear with a bunch of fat in the muscle that can't be repaired, open up the shoulder, and then go out to the family and go, I couldn't really close that big hole that's supposed to lift your arm up, and we got nothing to help you with. So this helped answer that problem as one of the reasons we do a reverse shoulder surgery. And he's going to give us 3 or 4 main reasons this surgery has really helped us in difficult situations.
So is it optional? I can either go standard or go reverse, and Is it up to me? Is it up to you? Who decides?
Well, it really is up to several things. One, I think it's up to the surgeon and their comfort level with two of those procedures. And we can get into the more specifics of those because there is an anatomic total shoulder replacement where the ball and socket is replaced with a ball and socket. A reverse shoulder replacement classically was used for patients that had arthritis but also had a very large rotator cuff tear. And most of those patients had significant pain and dysfunction that they couldn't actually raise their shoulder up at all.
Okay.
In the reverse shoulder, since it changes the anatomy, it allows our deltoid, which is outside of our rotator cuff, but a very powerful mover of the shoulder, take over and provide most of the motion to the shoulder joint.
All right, time for a touchy-feely thing.
Oh, my gosh.
So
Yeah.
reach the outside of your shoulder. That big round muscle on the outside is the deltoid.
Yeah.
So when the muscle underneath the rotator cuff, which is a front, top, and two back muscles, are not very good, this round muscle is almost always good in almost everybody. We are then using that muscle to move the arm. And so the key to shoulder replacements, whether it's a standard or a reverse, anatomic or backwards, whatever you want to call it, what you're doing is improving pain and function. And those two things are the greatest selling point for this procedure. This is a very, very well accepted procedure by the patients. They're happiest probably with hip replacements. Shoulders are a pretty close second on satisfaction when they're done right by the right person with the right solution. But it restores pain and function, which is tough when you can't reach your hair, you can't put a dish on a shelf, or you have been told your 2 or 3 shoulder rotator cuff repairs just aren't working, or they've retorn again. Then you go into some of these options. So the rotator cuff that isn't very good, or the rotator cuff that's already torn with arthritis, those 3 things together lead us to which of these two?
Yes.
Yeah, so is it?
Yeah, so the reverse shoulder replacements here on my right. I think it's a key point, and I try to explain this to patients when I see them in office. The rotator cuff, which is a collection of 4 muscles, which you have covered before in previous podcasts, is responsible not only for motion of the shoulder, strength of the shoulder, but also stability. So what I mean by that is if you lose the stability, your shoulder can kind of go in a different direction. The best way that I like to describe it is a balloon. If I fill it up with helium, I let the balloon, it will continue to go up. If you lose your rotator cuff, which provides some stability to the shoulder, your shoulder actually migrates upwards. Now, you don't really feel that clinically. However, it dramatically decreases your function. And we have some terminology in orthopedics. We say patients are what we call pseudo-paralysis. Pseudo means false, paralysis means you can't move. But as Dr. Urse was describing, a lot of these patients can't even raise their shoulder above this level.
What causes that in most cases?
Most of the time, it could be some nerve injuries, but most classically in my practice is individuals with massive rotator cuff tears. Because they have lost the ability of that rotator cuff to provide some stability to the shoulder joint, they're now basically riding up a little bit higher on their x-rays, and the shoulder rides up like that, and they just can't keep it contained in the joint, and then you lose the function.
Yeah, think of a rotator cuff like a rip in a tissue. As you use it and don't fix it, it just tears more. It doesn't have a way to fix itself. So we do fix rotator cuffs when we see them, when they're indicated with what's called pain or loss of function. But if you don't fix them, then they get fat or muscle wasting, kind of like our tummies a little. And then those become more difficult to fix later. And if you can't fix it, then you have to say, if I put in a new shoulder replacement, an anatomic normal one, what if the rotator cuff's not there to lift the arm? Well, you got great looking x-rays. I think we have show them an x-ray of a shoulder there. So we have a great looking x-ray, but now you don't have function. You don't have the ability to lift the arm because the rotator's no good. Well, the reverse shoulder fixes both of those problems, the arthritis in the joint, but it also lets that deltoid muscle lift your arm or power the arm, where the rotator cuff wasn't able to do that.
So what is it that would cause this problem to happen most often? Is it in males? Is it in females? Is it golfers? Is it tennis players? Is it just a random thing?
Well, I think if you're describing like rotator cuff tears in general, that can be in any patient population. The individuals that go on to develop this weakness and pain, it is varied. We don't really know why some individuals who have large rotator cuff tears can't move their arm and others can't. We do know that once you get into 70, 80 years of age, the percentage of those patients that have torn rotator cuff tears that have no pain is pretty high, upwards
Really?
of 30 to 40%. But they don't have pain, so we just treat them conservatively if they come in and they have decent function. A reverse shoulder replacement, as it classically was made, was those individuals that couldn't raise their arm up at all. So they were significantly debilitated. So originally they had what we call a partial shoulder replacement. It would improve some of their pain. It wasn't great, but it wouldn't help them with their function. So in this model here, just to...
By the way, these are very fancy. These are way fancier than the ones you've been bringing in.
I brought in the big guns today.
Yeah,
Look at this.
that's right. And to do a little, I'm trying not to hit the microphone here, but
That's all right.
To do a little biomechanical lesson, but not too significant. This is the cup portion of the ball and socket joint, and you can see there's now a ball on it. And
So
there's-
that bone is your shoulder blade, just so
Correct.
people, you can feel the
point.
top of your shoulder, and then the arm bone, which is your humerus, is where the ball part of a normal ball and socket of
Right
a
here?
shoulder is.
Right around here?
Right, and it's
Okay.
deep. And essentially, now you have a ball on the cup portion, and you can see on the arm portion, you have a cup. And I'll swing this around so you can see, and it kind of goes in just like that. So it's a completely different anatomy. You can see we got rid of the head on that side, and we put the ball on the other side.
Now,
And
is that what the normal shoulder looks like? What is that one right there?
So
The
this
other
would be a regular shoulder replacement, or what we call an anatomic shoulder replacement. You can see the
ball.
ball looks the same.
Yeah.
Well, it's metal in this particular type of device, and then the cup portion, we put a little piece of plastic on the side.
Yeah, and
so
just
it's
like-
normal. It's normal anatomy.
Yeah, and just like the hip, when we talk about arthritis, we've talked about that. The cartilage, which is the gristle at the end of a chicken bone, wears down. The bone rubs on bone. That's what causes pain and arthritis. You can see that the ball replaces the arthritis part of the cartilage, and then the socket part is this little kind of receptacle portion called the socket of the shoulder. So a standard shoulder replacement, if you saw somebody, say he saw somebody younger who had a good rotator cuff but just had arthritis, Dr. Malarkey would say this may just need to have a shoulder replacement like a hip or knee that doesn't need a reverse. That's a standard shoulder because the muscles that move the arm are all working. And we would do an MRI ahead of time, sometimes an ultrasound based on whether you had a pacemaker or something.
Well, that's
But then
kinda-
the surgeon would evaluate your muscles by examining you. So we never skip steps in medicine. We see patients, we examine them, we look at tests, we then find out what is their demand or what is their issue. They may have a crappy x-ray and a shoulder that doesn't hurt. Well, we're happy that they don't need anything done. But then if they don't have function, if they don't have a rotator cuff, if they have pain, then you decide, well, what's going to be best for them? That's where the patient needs to do their homework. You want to look for somebody, and I always tell people when you're trying to find the person, and this podcast goes around the world, so if you ask 5 people to give you 3 names of people that do great shoulder surgery around you, 1 or 2 names is going to be on everybody's list.
Yeah.
And I would tell you in a big procedure like this, you want someone who's done a fair number of these that knows what they're doing, because there are complications of every surgery. And again, if it's put in too loose or too tight, it doesn't move or it wobbles.
Which one's harder to do?
Well, I would tell you an anatomic shoulder replacement is harder to do technically. It has a little bit more what we call balancing. So not to get in too great of detail, but the reverse shoulder replacement has a little bit more what I call constraint. When you pop it in, similar to a hip, it almost has a pop. You put it in, it feels nice and stable. A regular shoulder replacement, you're relying on a little bit more of the soft tissues,
Okay.
the rotator cuff, the ligaments around the shoulder to balance it is the best way to describe it. I was mentioning this earlier, but the reverse shoulder replacement, you're changing the anatomy, so you're actually moving what we call the joint line in a different position, which allows it to function appropriately.
Now, can I play tennis after this whole thing's
Absolutely.
done? So
Absolutely.
it'll be just as good as new?
Well, yes, it's a great operation, but I always caution people that it depends on what you're getting the reverse shoulder replacement for. So we have discussed here over the last few minutes that rotator cuff deficient shoulders are probably the number one usage of this, but we're finding that it has usage in other patients as well, including patients that have arthritis with an intact rotator cuff.
Okay.
There are several things I always tell patients in terms of range of motion, specifically with the reverse. If your rotator cuff is not intact, you don't increase to the extent that you would on a regular shoulder replacement, what I call external rotation. So if you put your arm at your side and you just keep it at your side and externally rotate it, and you don't have a rotator cuff, you can get some of that back with the reverse because your deltoid allows you to do that and the position of the implants. But one of the big things you lose with a reverse shoulder replacement is what I call internal rotation, which is the ability to put your arm up your back. So I always tell patients that, well, you might not be able to scratch the mid portion of your back. Now, a lot of these patients, but they have severe arthritis or a rotator cuff deficient shoulder, can't do that anyway. So as long as their pain's better, they don't care. But those are two areas where you have to be very mindful and the patients understand. You might lose a little bit of external rotation. Okay, you might not have great external rotation anyway.
Turn your palm out.
Yeah.
And then internal rotation with your arm up your back. But to answer your question more broadly, can patients go back to lifting weights? Can patients go back to swimming? Can they go back to pickleball and tennis and golf? Yes.
Okay, that's
Yes.
great.
We do know in studies that individuals that have a regular shoulder replacement or an anatomic shoulder replacement and a reverse shoulder replacement, they will tell you it feels a little different.
To them,
it feels
this shoulder versus that
correct.
shoulder.
It feels a little bit more natural to replace the shoulder as it was designed,
Right.
which is the ball and socket joint. So they will mention that because there is some restriction of motion. But it's been in my experience and in the research that we look at that patients that have rotator intact shoulders that get reverse shoulder replacements or get an anatomic shoulder replacement, if we look at certain range of motion parameters and certain scores that we use in orthopedics, they function very similarly. So it's a great operation for even patients that have intact rotator cuffs.
Let me give him one more reason we might do a reverse, and then let's talk a little bit about like the recovery period because people want to know. I think another indication for this is if you have a very bad fracture where the upper part of the arm is in 3 or 4 pieces, or the crack goes into the joint, and then those rotator cuff muscles that attach to that are now going to have trouble working. In that case, instead of being Humpty Dumpty and putting all those little pieces of bone back, the reverse outsmarts the body again. It then uses the round muscle, because remember, the rotator may be okay in this case, but the bone attachments to it are now crumbled or in too many pieces or in soft bone. It's not what's called osteoporosis. So in those cases, that would be another more of a traumatic origin instead of a wear and tear, arthritis, or rotator cuff problem.
So let me ask you, before we go into recovery, I'm one of these guys who always want to know, how long am I going to be out? How long is this thing going to take?
Well, we just said we're going to go over the recovery.
Well, that's not recovery. That's put me under and
Oh, you
cut
mean
me
the
up.
surgical
Yeah.
procedure?
the surgery.
How long does it take?
Are we in a hurry?
Well, I didn't think we were, but Terry wants to know how long it takes. Well, it depends. It depends on what you're doing it for. I want to mention something about the reverse shoulder replacement for fracture.
Yeah.
You know, when we talk about orthopedics, we mentioned total hip. That was a game changer. I really believe a reverse shoulder replacement is a game changer for not just shoulder surgery, but orthopedics in general. And fractures or broken bones around the shoulder, historically, if you couldn't fix them, most of them can be treated without surgery, which is great. But we've kind of gone through several iterations of fixation techniques, plate, screws, nails. And then we'd have the ones that we just couldn't fix at all. And once again, we were using partial shoulder replacements for those, which is almost a thing of the past. But when that didn't do well, those patients didn't do well at all. A reverse shoulder replacement has reliably allowed patients that have really bad breaks to continue to raise their arm up and do what we call activities of daily living. So that is another just huge indication for this particular implant.
We would fix these fractures in the upper arm like a puzzle. And we'd all high-five each other at conferences. And we go see the patients, and they're like, hey, doc, why can't my arm work? And it's like, I don't know. I did a great job. I got 2 high fives at the fracture conference. But we were not happy with our outcomes in a lot of cases. That didn't mean we didn't get good outcomes, but it was a very frustrating problem that reverses have helped solve.
All right,
Big time.
so by the time the nurse walks in, preps me, gets me into the room, you put me asleep. How long does it take you to do this?
It depends on what I'm doing it for. And I want to answer your question. One last thing is that significant deformities of the shoulder, even when your rotator cuff is intact, that means that over time arthritis just creates deformity in everybody, whether they're hip, knee, or shoulder. That's another great indication for it. And that kind of leads into the question how long it takes. If you do a reverse shoulder replacement for fracture, depending on how you do it, or for a break, it could take you anywhere from an hour to an hour and a half.
Oh, that's
if
not
you're
bad.
doing it for a rotator cuff deficient shoulder with arthritis, it could take you even 45 minutes.
Really?
It just kind of depends. I would say on average, if you look across the country, it takes about 90 minutes for this procedure. And you want to make sure you do it correctly. But that's about on average how long it takes.
And you're out. This is not one of these partial anesthetics, right?
This is a general anesthesia.
Okay.
Now, there are a lot of things we can do to help the pain afterwards. I'm sure you all have talked about this in the past, but we do nerve blocks. We can do certain injectables around the incisional site, and then we use multimodal pain medication afterwards, which means that we give anti-inflammatories and other narcotic medications if needed. But this is a general anesthesia, and that's why when you come see me or Dr. Urse, we talk about surgery, whether it's a shoulder or anywhere else, there are risks associated with that, and we've gone over that in the past. But it is a general anesthesia to have this operation.
So let's get into that recovery that you've been dying to talk about. What is my recovery for this? I just had it done. What happens?
It's going to be surgeon specific. So some surgeons want you to do a lot of therapy. Others say stay away. Stay in your sling.
Really?
For a certain period of time. How long do you keep your people in slings?
I'm a little bit more, I'll call it conservative when it comes to my reverse shoulder replacements. It's how I was trained, but I also find that I'm never really that concerned about patients getting their motion back. We do a lot of releases during the operation, which means we do a lot of dissection to get exposure. So I never worry about these getting too stiff. I tend to slow my patients down. I have another reason for that as well, is that I repair at least a remainder of the rotator cuff that's still present. I actually put my patients in a sling for about 6 weeks. And by doing that, I take them through self-directed exercises, and I call these pendulum exercises. You basically let your arm dangle down like that and just kind of swing it back and forth.
All right.
And that's all I do for the first 6 weeks. I kind of let their shoulder accommodate to this new implant.
Is there therapy involved?
And therapy can start early. I have some of my partners and colleagues who start therapy really quickly after these, as in within the first week or two.
Yeah.
I tend to delay it until about the 6-week mark, and even then, I take them through a self-directed therapy protocol as well.
Okay.
I would say 95% of my patients that get a reverse shoulder replacement end up doing therapy on their own. And that's just been my experience. I've been very happy with it. That being stated, as Dr. Urse has mentioned, it really is surgeon dependent.
Okay.
Well, we talked at one time about when can I drive after a surgery? Well, if your arm's in a sling and you're trying to get to therapy 2 weeks after surgery, now you got to find someone to drive you. You've got all those issues. So anything we can do where a therapist comes to your house, or you don't need the therapy and we can show you what we want you to do. Remember, when the arm's in a sling, you can still use your hands, your wrist. You can play your solitaire games on the computer. As long as the elbow's by the side, you're not hurting the shoulder. I always tell people you can conduct the Cincinnati Orchestra with a shoulder surgery and never hurt your shoulder. But again, you always want to ask your doctor, what should I do? What do you want me to avoid? And let's make it a win-win. The patients want to get better too, but the doctors just put all that work in to fix the problem, and they don't want you going off on your own going, I think I'm going to try, throwing some baseballs next week. Well, most people aren't going to do that.
So one of the most important things, and as we kind of wind down here, is if I'm needing something done to my shoulder, what are the things I should look for? What kind of surgeon? What are the things I should be looking at? The hospital I go to? Are there certain doctors I need to be? What is it I should be looking for if I'm Googling things?
Well, I mean, once again, I think above all else, you should find a surgeon or a physician that you feel comfortable with. Someone that's willing to sit down and talk to you about the procedure, talk to you about what the expected outcomes are, talk about what the risk of the operation are. And I think
what are the risks, by the way? We didn't really cover.
Yeah, and I think, as in most risks with any surgery, infection is always one. We do give you antibiotics. Bleeding is another one. There's two main risks that I'd like to really hone in on a reverse shoulder replacement, and I really emphasize these two patients pretty critically during my initial consultation with them. Number one is a dislocation. The reverse shoulder replacement can dislocate. Now, a regular shoulder replacement,
Which means it's popping out of the
Yeah.
socket.
Good point. Popping in and out of the socket. Now, a regular shoulder replacement can do that. It's a little more subtle. When a reverse shoulder replacement pops out, it pops out. The ball and socket they're no longer engaged.
So I'm not Tom Cruise slapping it back.
Yeah, exactly.
Okay.
And
Just like a hip replacement.
it's
If you have
like
a total hip that comes out, you're probably not going to be able to put it in yourself.
Yeah, yeah.
Okay?
And
you're going to an ER, or you're going to have somebody on the golf course who's really smart
Right.
popping
Yeah.
your
Right.
hip or shoulder in.
Right. So that's one. Number two is a thing called a stress fracture. Okay. And I don't want to get into the weeds of this, but sometimes, and there's risk factors for this, but sometimes individuals get what we call a stress fracture after a reverse shoulder replacement. And that is essentially a stress fracture where a bone is taking a lot more stress, hence the name, and it can crack. And if you kind of feel on the back part of your wing blade there, that bone back there, you can kind of feel that hard spot right there. That can actually break after a reverse shoulder replacement. We have theories why that happens. We're getting a lot better at decreasing the instance of that, but I think it's so important that patients know that because they are miserable when that happens. I mean, miserable. They regret having the surgery. They don't like you. And it's something you just really, and if you don't tell them, they can get very frustrated because this is unique to the reverse shoulder replacement.
Do you know that going into that they're running a risk of that?
Yes, and there is a subset of patients that I get very worried about.
Okay.
And those would be individuals that have osteoporosis, have what we call rotator cuff arthropathy, which is a term used that we've been alluding to the whole time, which is a large rotator cuff tear with arthritis. And it tends to be a little bit more common in females, and another condition called rheumatoid arthritis, or what we call the inflammatory arthritis, which is a different subset of arthritis than our typical kind of wear and tear.
Okay.
So if I have those individuals, I always caution them that this can happen 2 to 4% of the time, and when it does, it's pretty devastating. So there's things that we can do, and we're getting better at decreasing its occurrence. And there's things we can do afterwards when it does happen, but I just think it's so important that everyone talks about
and this is
that.
a pretty thin little area where the shoulder blade meets the ball, and that is the end of the shoulder blade is your socket. It's a pretty thin area, and again, we're putting little screws and things to anchor the actual thing called a glenosphere. And there are risks of any time you're putting in I guess a hole in a bone. And we talked about a hairline crack or what's called a stress fracture. And these are just a little more stress, like, you're putting pilings into the ground, and it might crack a piece of the concrete or something. There just depends, what the bone quality is like. We can't always tell how hard somebody's bone is when we work with them. We see x-rays, some of them give us a little indication of that. So your surgeons that are careful, that are looking to avoid problems, are ones you should investigate. Just like a restaurant or a movie, you usually ask some people, hey, what's a good restaurant? What's a good movie? Who's a good surgeon you know? Your doctors, your healthcare providers usually say, gosh, I've had my patients go see this person. They've done a great job for my people. That's a good start, right? And we talked about asking other people who they've seen. Ask your therapist. What doctors are sending people to you that are getting great results? That's a good start. So I think word of mouth is really good for things. You have Google and
I do have
all
Google.
the other search engines too. But I think you need to do your homework on big procedures. I always talk about like a mitral valve replacement of your heart. I mean, somebody should really know what they're doing if they're going to do that to you.
I would hope so.
You don't want to go to a community hospital in a rural area where they do one a year and say, I think we feel like we could do that. It's like, I wouldn't do that. I would go to a big center where people who do this surgery routinely and have this, team. And he has a great team around him. He's got people in the OR that help him. He has people in the therapy department if needed. We've got, support people that answer your calls when it's like, hey, I've got some.
And this is Orthopedics
soreness.
Associates we're talking about.
Well, it is. Well, I'm talking about that with him. But every physician relies on other people.
Sure.
Every quarterback relies on a tackle keeping that blitzing linebacker off him. So we all, smile and say, hey, we're doing all the work. But there's a lot of people that help us get results and sometimes warn us when a problem's occurring. Like, hey, I got a phone call from, Cindy's got some redness in her arm. Let's get her some antibiotics right away. There are things that help us help the patient, and always stay engaged. I think our communications are better now. There's some text messaging we do after surgery now, some, more, awareness for both the doctor and the patient. You have these, my charts and different accesses to your records where the patients and the doctors can communicate a little more freely.
So, Dr. Andy, as we're winding this down, is there any last thing we should be telling folks that maybe we didn't cover?
Yeah, no, I think we've covered a lot of topics on this particular implant that we have. I will tell you that we mentioned this briefly at the beginning. If you have severe arthritis in your shoulder and you failed the conservative treatment, whether you see this new surgeon or not, it's not always one or the other. You'll have people that come and say, well, I want to reverse because it's better, or I want this. That's not always the case. I think this has revolutionized shoulder surgery, but I think if you have a conversation with your surgeon, you feel comfortable with your surgeon, and there's reasons why he or she chose a particular prosthesis, I think that's the importance. I think this shoulder surgery, while it's amazing and it's done awesome things for the shoulder, it might be overly done in certain situations. So I think it's important, as Dr. Urse has alluded to, do your homework. Go to someone you feel comfortable with. Go to someone that does a lot of these. I mean, the complications, the risks are not, they can happen. And when they do, it can be a very difficult thing. But, go in with kind of an open mind. If you decide to have surgery, understand why you're getting one versus the other. And there's some bias there. I mean, there's some surgeon bias of what they prefer to do. But I think we covered a lot of major points about this. Once again, I think this is completely revolutionized shoulder surgery just because it is so versatile. We can use it in a variety of different situations, in a variety of different patients that we didn't have 20, 30 years ago.
I have two comments. One, is there any nickel in this?
There are
in the reverses.
Yes, there are, and you can get special nickel-free
so
implants.
So if you have a nickel allergy, or you think you have issues with earrings, jewelry, certain metal reactions, they're testing for that, but insurances don't pay for it. But you tell your doctor about that. Second thing is, should we tell them how to find Dr. Malarkey?
Well,
how about oadoctors.com?
Yes,
and you can look up Dr. Malarkey's pedigree and his training in Transylvania University.
That's right. That's where it all started.
And I think that, again, we have a big old world of information out there. I want to thank Terry, Tri-Level Recording.
And I want to thank Santa for being Santa.
And let's thank our sponsors, tedsaladressing.com, and a great, authentic Greek dressing that doesn't have any gluten or any sugar or dairy-free, all those
It's actually
things.
really good stuff.
And then the GWR Group with Guy Richardson and his gang of their financial consultants. So
Smart guys, yeah.
We appreciate their sponsorship.
All right, Dr. Andy Malarkey, thank you for coming in today and joining us here on the Bone and Joint Playbook with Santa, Dr. John Urse, and we'll see you all again real soon.
Have a safe holiday.
Merry Christmas.